suction inflexible ureteroscopy is in the spotlight, and it's probably the way to go, but we need to generate more data on that. It can probably improve vision, improve our clearance rates, and also some advantages regarding intrarenal pressure. But we are in the beginning of this era. It's for me an honor to co-chair this session with a urologist, person, pianist, and a friend I admire, which is Dr. Cecilia Cracco. Grazie, Cecilia. And also my Italian teacher. So it's really an honor. And I invite to the podium Dr. Sierra, Dr. Alba Sierra, who's going to defend the option of suctioning through the sheath. Unfortunately, for flight issues, Dr. Traxler won't be here, and we will discuss among the three of us the other approach, which is the suction in the scope. So, Alba, it's my pleasure to have you here. The podium is yours.
Thank you very much, Daniel. So, well, hello everyone, and let's talk about fans now. I thought that it was the first time that I was going to be in a panel with Professor Traxler. I was a fellow with him a few years ago, and it was a pleasure to be with him, but unfortunately he won't be here. So let's talk about fans, and as Dr. Binit has said all around the world, we are all fans of fans, and let's see how. I think that the best demonstration is the surgery that we have already seen before with Dr. Gaumas, because it's the best way to see tips and tricks in a real-life surgery case. But let's try to go into details. For sure, I think it's a game changer, and I think that all this morning we've been talking about that, and suction, it's a new paradigm, I would say. If we can see the last years, the improvements in retrograde intrarenal surgery, and we focus on the last 5 years, we can see the amount of devices related to suction, the Ds and the fans that they are coming around the market, and the pressure monitoring sensors. Especially now with these 7.5 single-use ureteroscopes, now the highest working channel of 5.1 that we've seen before in the Ds technology by Pusen, and the fans that arrived in the market in 2022. Because before, as we all know, we were limited, especially because intrarenal pressure, and it causes different complications in our patients doing our surgery in terms of liquid extravasation and bacterial translocation. We know that the pielovenous reflux occurs after 40 centimeters of water, and the fornix, the rupture of the fornix, it comes after 90 centimeters of water. So this is our limit. And we realize, looking into literature, that we overpass the limit frequently in doing retrograde intrarenal surgery, going up to 500 centimeters of water. As you can see here in this demo, by increasing the manual pump, we are also increasing the intrarenal pressure in our surgery. And actually, we didn't realize that because we don't have a pressure to control that, a sensor to control that. And we talked also this morning about the energy that we are using and the heat that we produce due to the energy of the laser. We've seen this morning that up to 50 centimeters after 50 degrees Celsius, we have some thermic damage, and it's overpassed by using up to 40 watts in the kidney. And we've seen also that irrigation, even if we increase irrigation, we won't reduce the amount of heat that we are producing, so we need to reduce the amount of energy. Because we are, again, limited by the intrarenal pressure. We can increase the irrigation in our kidney in order to reduce the temperature, but there is a physiological limit. So as we are limited and we have to decrease the irrigation, so we will have worse vision, we also increase the irrigation, but we have more intrarenal pressure, which is something that we didn't want. And if we decrease watts, we will have longer operative time. The only way to expand those limits is by increasing the outflow. And with this idea, it arrived in 2022, the use of the flexible vacuum-assisted ureteral access sheath. It was reported for the first time by Dr. Chen in China, and it was the first time that we placed this ureteral access sheath over the pieloureteral junction. We have seen with recent publications that we are expanding the limits because now, by doing retroactive intrarenal surgery, we can treat stones more than 2 centimeters, which was established as the maximum limit, and over that, we should go to PCNL. And also, we realized that by using these suction devices, we are increasing the stone-free rate, as we've seen before, also with 0 fragments. The best match, it seems to be the 7.5 flexible ureteroscope and the combination with the 10-12 flexible fans to access to all the calyces and to remove all the fragments. We might think that it will reduce the operative time, but according to this publication in its prospective randomized study comparing the conventional ureter access sheath with the flexible with the fans, we realized that we were not reducing the operative time. Is it true that we reduced the number of rescheduled to reschedule the surgeries, and also we realized that we have these no fragments at the end of the surgery, but the surgery was still longer. This is maybe because this video is not working. Well, it works before. Oh, okay. Well, we realized at the beginning, sorry, because we were like removing fragments and we were trying to put all those fragments inside our ureteral access sheath. But this was a really time-consuming procedure because we were like putting all the fragments inside the ureteral access sheath and then going backloading the scope with the fragments inside. Now, I'm sorry, this is not working, but now the way to do it, as we've seen, I think that the best way it was to look into Dr. Gaumas before. It was working next to the stone and then making some small particles, some dusting, and then this will let to get out, and this will be the final result by having all these small fragments with our final recipient. In this recent systematic revision, we have this application of phantom flexible ureteroscopy, which led us to increase to up to 3 centimeters. It's also useful for kidney and ureteral stones. We can use it in a bilateral way for pediatrics and adult population. We are looking for these 0 fragments. It's reducing the intrarenal pressure, which was one of our limits, and with less complications by reducing the complications of sepsis. But it has some problems, as we've seen before. We are adding some surgical complexity. We need another assistant to help us, as Dr. Gomez has said before. Also, we're adding more devices in our OR. We are not clear what about the irrigation settings we have to use, if these manual pumps, if the automatic irrigation, or still using the pressure bag. Also, the suction. There is a lot of variability on that. In my hospital, we are using the Neptune, that you can also put some parameters on it, but it's not clear what we have to do. And then you have also this central vacuum aspiration from the hospital, and it depends on how many ORs are using it, that it will change the suction on your own OR. So there is a lot of suction variability. And for now, they are 2 independent systems. For one, we have the irrigation, and for the other, we have the suction. So this video is not going to work. Oh, sorry. Tampoco va. Es que antes iban los dos, que lo hemos probado fuera. Sorry. I think that maybe because of to move from our computer. I wanted to show you here that the system was collapsing because of the irrigation, and it's just because the irrigation and suction are independent that we are collapsing the system, and it's difficult to control with a proper irrigation and a proper suction. And there is also sometimes that we have a blockage in our system, so we maybe not realize, but the pressure inside the kidney for now is increasing because we are hoping that there is some suction. We are pushing so much the irrigation system, and as the suction is blocked, we will increase the irrigation without notice. And again, this will be the problem, the increase of the intrarenal pressure that we were looking to avoid at the very beginning. This might be a solution. These are these new non-invasive intrarenal pressure monitoring devices. You can see here that there are different sensors that you can place inside the renal pelvis, and they can control the pressure to let you know what's happening inside the kidney. And this might be a solution, but again, this will add more complexity. If even we now are not sure how to use the laser, we don't know where to place the irrigation, what to place the suction, and then we are also placing these intrarenal pressure devices, we are just adding more and more gadgets, making our surgery more complex, which maybe it's not the solution. And what about the UPJ fragility? We are now overpassing the UPJ using this 12, in the good cases, we are using the 12 French ureteral access sheath, and this can also damage the ureteral junction. What we know, it's fragile already. In this study, they realized that when the patient was pre-stented, we reduced the amount of ureteric injury in the level of the UPJ or in the proximal ureter. So maybe this also forces us to place a double G when we are going to plan to use this Fentes technology. As you can see here in this CT scan, there is a rupture of the UPJ junction with the urinoma after performing this surgery, which this maybe will be a problem that we will see more often using this technology. So the disadvantages of this technology is that we are adding more complexity to our surgeries. We don't have still some definition in irrigation and aspiration settings, and for now they are two independent systems that we need to put together. And what about these UPJ injuries that we are maybe going to see in the next future? I was hoping that Dr. Traxler will give a light on that, and maybe this will solve all the problems, but we will discuss on that. So thank you very much.
So Alba, maybe the question could be, what do you think of digital in-scope suction compared to suction access sheet? Do you think both things have to be combined, that one is better than the other as a solution?
I think that in terms of technology, with flexible ureteral with fans, we have reached the maximum, which is the smaller size as possible, the flexibility of the tip of the fans. But with this, we didn't know, we are just in the beginning. We are looking, like I see the CVAC is the way to do, with two different, one irrigation channel and one suction channel independently, because as we were watching with Pusten is that if we aspirate and we remove the irrigation, we are going to collapse for sure the system. So maybe the way is to improve still the Ds a little bit in the future with technology improvements.
Artificial intelligence has to help us because inflow and outflow have to be perfectly balanced, because it might happen that intrarenal pressures are measured as normal and irrigation is going elsewhere, maybe through a fornicial rupture, so you measure a nice intrarenal pressure, but irrigation is filling the abdomen of the patient, and we don't have to rely completely on technology, but also to use clinical sense.
I completely agree.
So to me, theoretically, this makes sense, because if we are honest, our results in flexible ureteroscopy are not that good. So we always have residual fragments at the end. And we always think that they are going to pass in the next weeks, but they don't. And not all of the patients have a CT scan 3 months after to make sure there's a zero stone-free. So it makes sense. But on the other hand, it's quite difficult to balance the inflow and outflow when you use these sheets. So can you give us any tip, if you can, or how you do it in the hospital clinic, to have the kidney not very dilated, not very collapsed, but at the same time being effective to catch the stones with the tip of the sheath?
Usually when we are doing flexible with the conventional sheath, we use the pressure back. But when we are starting to use this technology with suction, we use the automatic irrigation pumps, which helps you to increase a little bit in some cases and to look for this balance, I would say, with the automatic pump. So we place it usually by using up to 100 centimeters of water, which is more than the usual that we use, because it helps also to have more flow at that time. And with doing that, and also as Dr. Goma said, working next to the stone, very close to the stone, it helps us to have a good control of the vision, avoiding the collapse that we were having at the very beginning. So with the automatic pump and then working really close inside our sheath next to the stone, it's like how we are managing not to expand and not to collapse so much the kidney.
Do you always pre-stent patients, or you select patients with stents for this technique, and those who don't bear a stent, you evaluate UPJ and then you decide?
Yes, as we are learning how it works, for now we are just choosing some patients that we think they have infective stones, so this will help because it's a soft stone, so all the small fragments that we are producing, we can suction them, and they are always pre-stent before doing this surgery. So for now we are selecting the patients that we are doing this. It's not our standard.
I would like to make a call to all the people using this and fans, because the problem of the current publication is that all the post-operative controls often lack CT scans afterwards at a standardized time, and X-ray and ultrasound to say it's better than standard intrarenal surgery is not enough. So this would be very, very important, because there are costs. A retrograde intrarenal surgery is becoming, you said that, very complicated, very complex. You have to use a lot of devices, a lot of accessories, and maybe sometimes I would think that maybe percutaneous surgery would be much easier and don't risk and ruin and destroy the ureter, because you know we have a lot of ureteral stenosis, and this is also an important issue to assess after the use of these fans.
Actually, I think that this is something that we are learning how to use it, but as we are adding complexity, I think it's not useful for all the population. If we are going just to treat one stone per month, fans is not the way to do it, because it's more complicated and you are not used to that. So maybe this is something for big centers with a lot of volume stone cases that
A lot of money
and
also.
a lot of money also.
Okay, so I think it's something we will comment on in the next courses, and the future will tell us who's right. Probably none of this. One, I don't know.
It will change.
Thanks. Time will tell. So thanks, Alba, for your nice presentation, and
Thank you too.
big applause to Dr. Sierra.